Family Conference. This is Paige Nuez with RettSyndrome.org, and on behalf of our Board of Directors and team, we're so pleased to bring you this week's series of free webinars to elevate your understanding and deepen your knowledge of Rett syndrome research and care practices. Your children are incredibly important to us, and having your attention and engagement today demonstrates your deep commitment as well, and we're so happy to have you with us. I'd like to say good evening to some of you and good morning to our presenter, Jenny Downs, who is coming to us from Australia. Thank you for getting up early this morning to join us. Before we begin the webinar, if this is your first webinar of the week, I'd like to go over some of the logistics of how the application works. The audio feed is open only for our presenter, so you don't have to worry about your background noise interfering with the presentation. If you look to the upper right corner of your screen, you'll see a control panel window. And we invite you to write your questions into the question box at any time during the presentation, and we will field all of your questions at the end. And if we don't get to them, we'll certainly do a QA document afterwards and email out answers and responses. I also wanted to remind you that this session will be recorded, so please don't distract yourself with having to take notes. We'll record the session and send you the link afterwards. We would like you to be able to focus on the material presented. If that control panel window is distracting to you, you can click on the small orange box with the white arrow to minimize the window, and then you can click on it again to expand if you wish to submit a question. If you have any trouble seeing the slides that are being presented, just exit out of the application and restart it. It should reset you just fine. Okay, so with those logistics aside, I would like to introduce Jenny Downs, who's a pediatric physiotherapist, or physical therapist, as we say in the US, and has been a researcher since completing her PhD in 2003. She's a senior research fellow in the Child Disability Group at the Telethon Kids Institute in Perth, Australia. She's been a good friend of mine for very many years and a good friend to all of us in the Rett syndrome community. Her research focuses on rare disorders, including Rett syndrome, and she's been involved in many studies of functional abilities and especially scoliosis. And we're so glad to have her with us today to present on this topic. So what we'd like to do now is turn the screen over to Jenny and let you go ahead and get started with your material so that you can get through all of your talk. And again, everybody who's attending, if you have any questions at all, please feel free to submit them in the question box and we'll field them at the end. Thank you, Jenny. I see your webcam.
Okay. You can see me. Are we all fine? Thank you, Megan, very much. Thank you, Paige, and thank you to RettSyndrome.org for hosting this series of seminars, and also to all of you who are here listening. My topic is scoliosis, and I would like first to let you know that there is we're a very busy and active team working with Rett syndrome research, and we're based here in Perth in Western Australia. That's a long way away from most of you because we're one of the most isolated cities in the world. We work at the Telethon Kids Institute, and this somewhat poor quality slide shows us as a team at the moment. Many of you will have met Helen Leonard. Dr. Leonard established her Rett syndrome research way back in 1993. There's myself at the back. There's also Amy in red and Nader at the very back, and many of you will have spoken to her. They work with our Interret study, and there also are a few of our current students. So we're always a reasonable size study team, and I've been with the team for over 10 years. And the basis for the data that I will present to you today is our Australian Rett syndrome database. This is a database that, as I said, Helen established in 1993, and since then, that's over 22 years now, we have recruited newly diagnosed families with a newly diagnosed child with Rett syndrome for over 22 years. And then subsequent to being registered with our database, we then collect family data and also clinician-reported data. So our family data in particular has been collected on many occasions. We've had successive waves of data collection. So we now have a longitudinal picture on many of the girls in our study, and we supplement that with information from clinicians and also from medical records. So what this allows us to do is to work with what we term a very comprehensive outcomes model. So over time, we have the child, and we can look back at previous factors with regard to perhaps genetic factors, factors to do with her previous health, family health, social determinants, and then we can look forward to a whole range of outcomes about her health, about any adverse effects in relation to any interventions, accessibility to services, whether they were acceptable to the family, and of course we're interested in family well-being. So with this longitudinal tracking, with this very rich set of data, we can also look at specific interventions. And in this presentation, I will talk to you a little bit later about outcomes following spinal fusion. So this presentation, as you know, is about scoliosis, and we have the human spine is a series of bony vertebrae. They are joined by ligaments and muscles, and they have a very important role. They protect our spinal cord, but also enable our upright postures. And when we developed the capacity to walk in our evolution as humans, we also developed two spinal curves. One is our lumbar curve, which is the small of our back, and also in the back of our neck, so we could support the weight of our head. The curves enable us to absorb shock, and they also assist with our balance. But the spine is actually quite a vulnerable structure. The vertebrae are all quite individually quite small, and many of us as adults will experience some low back pain. But for persons with altered muscle tone, the spine is particularly vulnerable because the capacity of the muscles to provide strong and symmetrical support to the spine is altered. And so a scoliosis may develop. And by definition, it's a sideways curve that you cannot fix by simply sitting up straighter. And this picture to the right of your screen shows you a schematically drawn diagram of a scoliosis. And it also illustrates to you how doctors will measure the size of a scoliosis by looking at the angles subtended by the vertebra at the top of the scoliosis and at the bottom of the scoliosis. And this angle, you may have heard about this angle, is called a Cobb angle. So we went very shortly after I started with our Rett syndrome research program here at Telethon Kids. We were hearing from the families who were participating in our database and were asking us a lot of questions. If their child had been newly diagnosed with scoliosis, they were saying to us, what's going to happen if their child had a more severe scoliosis and the surgeon was recommending a spinal fusion? They were also asking us, what do you know about this? What's going to happen? And so we knew from the literature that there really was not a lot written about scoliosis in Rett syndrome. And so we initiated a project that used a Delphi technique, which is a very collaborative research technique. And we developed a set of guidelines for the management of scoliosis in Rett syndrome. So this had at its basis a literature review. We recruited doctors, therapists, and importantly, of all the doctors that participated in our panel, we had spinal surgeons as well as child neurologists, geneticists, and pediatricians. So we really had a comprehensive panel to work with the statements that we generated and come to agreement as to what the baseline recommendations are. And what you can see on the right-hand side of the screen is the cover of our of our booklet. I've got here that it's available from our interret.org website, but it is also available from rettsyndrome.org website. And its set of guidelines are very general, and they're not a recipe for how to manage any individual child, but they give you a framework for determining what will work best for your child. So they talk about monitoring, they talk about promoting an active lifestyle, they talk about when spinal surgery is indicated, and they just start to touch on hospital management. And some of these aspects are areas that we have since been able to do more research upon. So I look forward to presenting those in this presentation. So the objectives for today are that we examine the onset of scoliosis and its later trajectories, specifically for girls with Rett syndrome. And for those who then develop a severe scoliosis, we will look at the impacts of spinal fusion on the girl's motor recovery. We will discuss family perspectives on that journey and tips that those families that we have spoken to have for other families, and we will also talk about later respiratory health after spinal fusion. So as I mentioned, the basis for this particular presentation is our Australian data, but we have also, and so we have a lot of numerical data, we have lots of numbers that we can work with statistically, but we have also interviewed families, and so we have qualitative studies as well. And you can see that it's not just our database that is informing our understanding of scoliosis, it's also information that we have got from hospital medical records and radiographic records of the spine. And you will see by all of those logos around this slide that Helen and I have tramped the Children's Hospitals of Australia to collect as robust a set of data as we possibly can to then build our picture of scoliosis in Rett syndrome. It was a lot of fun as well, going to make contact with each of the spinal orthopedic departments around our country, and hopefully this has been a very, very positive exercise in putting Rett syndrome on the map of these clinicians even more so. So first of all, the onset of scoliosis. Well, what we did know previously is that scoliosis occurs extremely commonly, and we have, with our database at its size at the end of last year, this is 394 girls, we have done a more recent analysis of the time to onset of scoliosis. And this graph is showing age along the bottom of the graph, and the likelihood of scoliosis, the percentage with scoliosis along the y-axis. What you can see is that approximately a quarter of girls will have developed, with Rett syndrome, will have developed scoliosis by the age of 7. About half will have developed a scoliosis by the age of 11. And then about 3/4 of girls will have developed a scoliosis by the age of 15. And so probably about in total by adulthood, it's between 25 and 20% of girls who will not have a scoliosis. And this is very, these data are similar to what has been reported from the natural history study, where they have looked at more than 500 girls and women, and approximately 50% of that sample at the time of their follow-up had a scoliosis. This is actually a broadly similar finding to ours, because many of the girls at the time of that follow-up were younger than 5 years, and so they would not have had a chance to have developed scoliosis. So in part, the age distribution contributes, but essentially the proportion of the conclusion that scoliosis occurs very commonly is consistent with both of our studies. So what influences the onset of scoliosis? Well, partly it is factors that relate to mutation. For example, I will show you in the next slide how the age of onset relates very clearly to the type of mutation, and also factors that relate to functional abilities, and we do know that scoliosis is more common if the child is not walking. And we would hypothesize that the activity provides functional strength to the muscles and does build some muscle strength and fitness, therefore providing some protection to the spine. So this is the slide which shows you the median or the average age of onset of scoliosis along the bottom, and the different common mutation categories along the left-hand side. And you can see that there are some mutations at the top that have a much earlier age of onset, and these tend to be mutations such as the R168X, the large deletion group, who tend to be associated with more severe clinical presentation. So those children do, on average, have an earlier onset of scoliosis. Whereas some of the other mutations, such as the C-terminal, the R133C and R294X, are generally associated with a milder clinical presentation and also with a later onset of scoliosis. So knowing that scoliosis is common and knowing that scoliosis can occur earlier and sometimes later, the next question for us was, how does this scoliosis progress? And so what we have managed to do is collect a very large number of data points, cob angles at multiple time points for as many of our girls in our country as we possibly can. And this is from going to the radiographic records at each of our children's hospitals. So what you see there is an extraordinarily busy picture and lots of single data points, but you'll see lots of lines where we have been able to collect a trajectory for an individual girl. And if you squint at that, you can perhaps see patterns. You can see that there are some girls whose scoliosis progresses very rapidly, and there are other lines where the scoliosis progression is less fulminant. It's much slower in its progression. So what we then did was put the if we had at least 3 data points for a particular child, we put that data into a model and then were able to determine the effect of age on the development of scoliosis. And this graph is showing you a summary line from that model and basically suggesting that a scoliosis is likely to increase with time. The scale of this graph makes it look like it is a very fast progression, but on average this equates to 5 to 7 degrees for each year of age. So we then looked at how this progression might vary by the type of mutation that the girl has. And what we can see is that most of the different mutations are associated, the scoliosis will be increasing with time. But what stands out is this line here, this line with the little light grey triangles along the black line. And this particular line is the progression of girls who developed a scoliosis who had an R306C mutation, and their progression was particularly small, and this stood out as being different to the other groups. So here we can see a group of girls who may develop scoliosis but are likely to have less progression of their scoliosis. We also looked at the progression, the trajectory of scoliosis by walking status. And here again you can see increasing age along the bottom and the cob angle of the curve for the y-axis. The top line is progression for those girls who are unable to walk. And you can see that they are particularly vulnerable to increasing scoliosis. The bottom line is the girls who develop a scoliosis but are walking independently, and their progression is less. And interestingly, the line just above that is represents girls who can walk but walk with assistance, walk with their hand being held or walk with their chest being supported, but themselves taking the steps And these girls also appear to have a much slower rate of progression for their scoliosis. And the fourth line represents those girls who were able to walk when they were younger, but then lost that ability as they grew older. And they also appear to be vulnerable to a progressive scoliosis. So here we can't claim that walking will prevent the progression of the scoliosis, but with that walking capacity, we can argue that it likely has a favourable, at least some role in mitigating the progression of scoliosis with time. So now we'd move on to the management of scoliosis, and here we're coming back to our booklet, which really talks about ongoing monitoring, an active physical lifestyle, and the possibility that fusion, a surgical intervention, may be indicated with a more severe scoliosis. We recommend regular observation of your daughter's spine, and if there are concerns clinically, then obviously an antero-posterior X-ray to determine if indeed there is a scoliosis present, and secondly, what the magnitude of that curve is. And if there is clinical concern, then that also ought to be referred to a spinal surgeon. Monitoring is usually conducted at regular intervals, often 6-monthly intervals or 12-monthly intervals, and this depends on if the curve is progressing and how fast, how young the child is, or exactly the magnitude of the cob angle, or also the capacity of the girl to ambulate. So the risk that she has for her scoliosis becoming more progressive. And you can see in these two pictures, the one on your left shows a spine which is looking very straight. Her shoulders and her waistline are very symmetrical. And the picture on the right, I've marked it with photoreflective markers, shows a girl whose spine is at risk, indeed has a scoliosis, and is being followed up carefully so that we're clear on what is happening to her spine. As part of conservative management, we have a thesis that the strongest body will be associated with the least development of deformity. The evidence base is extraordinarily limited with this regard, but currently our options to limit progression include bracing, stretch and activity, and very structured postural changes over the course of the day. And there has been some discussion also about overcorrection, which I will talk about. So in the first instance, there is the option of bracing. Bracing is used in some centres more than other centres. It is an area about which our evidence base is extraordinarily poor, but many clinicians have who use bracing have found it to be very useful for their patients, and so they will continue to use bracing. Other centres use bracing in a very limited way, so it is very much something that we see a lot of variation in practice. And this is something that it would be extremely important for us to potentially use our trajectory data to be able to look at what effect interventions such as bracing may have had on the progression of the curve, and it certainly needs further study. But if sitting is difficult for the child, bracing can have a positive impact, and it has anecdotally helped to reduce the progression and help to maintain a slightly straighter spine, whilst allowing for a child to grow more before thinking more seriously about the intervention of surgery. But it works so well in daily life, it can make it harder for children to move, and some children find a spinal brace very uncomfortable. And particularly if it's a very hot climate, then this can be very difficult on a day-to-day basis. So very much this is an intervention that needs to be carefully discussed with your clinician, and very much thinking about past experience of the clinicians and exactly how that applies to your child. It certainly needs more investigation. We also have the options of stretch and activity, and these two slides are from Maya Lotan. I love these slides because of the prone lying and the stretch, and the lovely stretch into extension of the little girl in the top left picture. But also here is one of Maya's clever ideas for stretching a spine inside lying. So this is nap time at this girl's school. She has a rest after lunch, and here she is with a little peanut pillow that gives her spine stretch in the direction opposing her scoliosis. So these are both activities that can be very much embedded in daily life, but maintaining stretch of our joints and our muscles has to be beneficial for our overall comfort and posture. We also have options of working with the girl's physical capacity in every way that is possible. For example, many girls with Rett syndrome are able to sit extremely well, including without having back support. And so embedding time and activities with stool sitting, and for example, for the little girl on the right, sitting here on her peanut ball and giving her spine time to work and support her posture is likely also to be helpful for her overall strength. Opportunities for standing. This little girl pulls herself up at that rail to watch the TV and then spends quite considerable time standing. This little girl needs a standing frame to help with her standing, and this one can be standing watching the TV with her dad. So lots of time in upright postures, and of course in a variety of environmental settings means that this girl can have the challenges of balancing in the puddles and in the sand of this very nice natural setting. So her muscles are getting a very nice workout that is supportive of her muscle strength and her muscle fitness, strength and endurance, I'm meaning to say. So all sorts of activities will be helping our girls' spinal muscle strength and endurance. So this again is one of Maya's slides, and this is where he, for some of his patients, has designed activities, changing positions and activities through the day so that there is variety. So variety of position with standing activities, walking activities as able, side lying with stretch, and other activities mean that there is variability in joint position, variability in muscle use, and this is likely to give better muscle strength and endurance, including in the spine. So in the guidelines, there is also a statement which talks about sleep positioning. So there's postural support when you're using a wheelchair, and that is a very clear standard practice. But there's also postural support during sleep. And these two sets of slides show how the child and the woman could be lying if they if they were lying on their backs and did not have postural support built into to their bed. And what I will show you in this next slide is what this particular system comprises. It's layers of a rubber mesh type fabric over the mattress that are that very much and then perspex brackets that grip to the rubber, and then there's nice soft sheets over the top of that which mean that it's very comfortable. But at the same time, here we're seeing this woman, she has a bracket at the upper chest level and also at a pelvis level, so that her sleeping position is made. She also has her head slightly raised. Her sleeping position is symmetrical with regards to her spine over quite a long period over the night. We have one woman here in Perth who uses this sort of system after she's, and this is post a spinal fusion, but it means that she has this continued support because she still wants to curl over to one side if she's allowed to do that. So she has this nice support over a long period of time, and that seems to be very, very useful for her. So this is a showing, and this again, just like bracing, this is another area of our management that we really need to investigate with good quality studies to understand the effectiveness. At the moment, they are anecdotally what we believe as clinicians to be appropriate management strategies that with your clinician you would talk about in relation to whether you thought this might be useful for your daughter or not, and there might be reasons why not, or there might be extremely appropriate. This particular mechanism that I'm showing in this slide is quite useful because the child cannot grow out of this mechanism, so it always it's always possible to use this no matter what your size is. So that's illustrating what is one aspect of what is in our booklet, but as I said, it at the moment is what we would recommend that you consider for your daughter, not necessarily what absolutely is right for your daughter. That needs to be decided with your clinician. So going back to our slides earlier where we looked at the progression of scoliosis, we saw that marked progression was not inevitable with every child who develops the scoliosis. And here you can see an example of a girl whose curve was a very similar size when she was a teenager to what it is now with her as a young woman. And so this is the benefits of monitoring, is that you're very clear on what is happening to your child. There are some girls for whom a scoliosis does progress, and if a scoliosis is severe, it can be associated with pain. It can make it harder for the girl to sit and to walk, and it will also affect the capacity of her lungs to expand, and therefore be restrictive on her breathing. And so doctors will start to think about a spinal fusion if the Cobb angle progresses to more than 50 degrees. So that's a marker where they're starting to think that this is something I need to consider for this child. And there are many contexts that doctors take into account. It's difficult to find out exactly how much, if the girl is in a lot of pain with her spinal posture, and because it's difficult for her to tell us that. And there are also other comorbidities such as osteoporosis, difficulties with reflux, with epilepsy, and also there can be increased sensitivity to anesthetic drugs. And with permission, of course, I just have a series of 3 pictures here showing a young girl who was just starting to show a scoliosis that you can see from these pictures continued to progress. And this is showing progression over a 4-year period. So as I said, clinicians start to consider the potential advantages and risks of fusion. There are short-term complications in association with such a procedure, which can affect the respiratory system or the gastrointestinal system. And later on down the track, there can also be a recurrence of scoliosis. So therein the surgeons work very hard to determine the best timing of surgery to work in with the child's growth, but also determine exactly the levels that they would be choosing to fuse. And at the same time that clinicians are weighing up the advantages and risks of the procedure for the individual girl, families also have many emotions. It's a roller coaster. Families are fearful of what the procedure is going to involve. Some feel obligated to agree to the procedure for their daughter. Some parents feel guilty that they couldn't prevent the scoliosis. And some families, when it comes to the stage of talking about fusion, sometimes feel relief that here is an opportunity for open discussion and putting all of the factors on the table which relate to the individual child. And what we do know from the literature is that after surgery, the literature suggests that the spine will be straight, symmetrical, and the girl will have better posture when she's sitting. There is some evidence for stabilization of respiratory function and digestive function. And the literature from several studies suggests that motor skills will at least be maintained at preoperative levels. So it's now my task to present to you data that we have further to that particular set of summary of information on what we've been able to find out, so that we can be even more informed as to the outcomes following spinal fusion. So last year, when we did put these analyses together, we had roughly 400 girls in our population. Two-thirds of those, in a cross-sectional sense, had a scoliosis, and of those, a half of those with a scoliosis had a severe scoliosis. So from our hospital records, we have 98 girls in our country who have, since 1976, undergone a spinal fusion. So this is becoming a substantial size from which we can learn what the outcomes are and take those through to the future. So what this slide is showing you is some details about the hospital stay. And this is for 81 of those 98 girls who, as I said, across our country have had a fusion. And this is showing you the proportion who experienced particular complications. The most common complication here in Australia was related to the respiratory system. And this was a diagnosis of a specific respiratory complication. And this occurred in 40% of this group. All of these respiratory complications did recover, but this was a short-term complication. There were nearly 30% who did have bleeding and needed transfused blood after their surgery. And there were a smaller proportion of girls who were over-sedated, two who needed antibiotics for a wound infection, and two who had some damage to their spinal cord during the procedure. But this was, for both of these girls, temporary. And on average, the number of days in ICU was 3.5 days. So the average days in hospital altogether was about 8 or 9 days. So really, it was quite a very efficient procedure to come into hospital, have the surgical procedure, spend some time in intensive care, and probably up to about a week on average on the ward after spending time in intensive care. So there has been one study that has looked at has collected data from a centre in the US, and this is a paper that the lead author has the surname Gabos, and they have reported 16 girls who have had surgery with Rett syndrome at their centre. Their average age of surgery was around 13. I will show you our data soon, and that is almost an exact match for our Australian experience. And on average, the Cobb angle was 68 degrees, very, very similar to our Australian experience. For those 16 girls, they have reported respiratory complications also, and they have also reported gastrointestinal complications, which we have not seen in our Australian sample. So again, it points towards the collection of this data, and the integration of data from multiple centres is extremely important to really give us a clear picture of the experiences for girls with Rett syndrome. And also, what they found in their sample of 16 girls, 6 of their girls could walk prior to surgery, and each of those girls maintained this post-operatively. So that is consistent with the literature. So coming back to our cohort, our girls with severe scoliosis, there are 140 in our population database. And one of our studies has been an interview study. And here we have recruited 24 families who have 25 girls who have each had a spinal fusion. One of those families had twins who both underwent a spinal fusion. And we asked about, we conducted very detailed interviews with these mothers, and we wanted to investigate the course of post-operative recovery and how their girls recovered their motor function, and we wanted more about the family perspectives. And we really drilled down with anything, any point that the mothers made in the interviews. We would say, how do you know this? Give me an example of how you saw this. So we could really map out the course of motor recovery. For example, if a girl was able to walk from the kitchen to the dining table before her surgery, but 6 months later at a family event she was walking from the beyond that table, we would have evidence that that skill had at least been maintained and was possibly stronger in terms of the distance that she could walk. So what we found was that during the hospital stay, almost everybody is sitting up out of bed in the first week, and by the end of the second week, almost everybody who had some capacity to stand or walk before their surgery has started to put those skills into practice again by the end of week 2. All of our families reported increased constipation and lethargy in hospital. Sometimes the girls just didn't want to eat their food. And so these are, particularly constipation is something along the side of the spinal fusion that needs to be looked out for and planned for and managed. Once they were discharged home, parents reported that their daughter's appetite, her apparent feelings of pain reduced, and her general well-being seemed to improve very, very, very quickly. And by about 6 months, we consistently, parents reported that their daughter's energy levels were very much back to normal, and and potentially they even felt they were improved. From the point of view of motor skills, parents reported better posture, and we were able to map out the return of motor skills, and it seemed that they returned to preoperative levels in most of this group by 12 months post-operatively. So this graph is showing you the regaining of the preoperative level of sitting. And you can see very quickly half the girls were back to their preoperative sitting level by 1 month, and the majority by 3/4 by 3 months, and almost all by 6 months. So there were some girls who took a little bit longer to recover their preoperative sitting ability. One was because she had an intervening femoral fracture. So you can see that other factors might occur and then have to be dealt with, and so this recovery is then delayed. One girl did, so this beyond 12 months, all but one returned to their preoperative sitting capacity. So this graph is showing you the return to preoperative standing, and on the right, the return to preoperative walking. And you can see that the rate of recovery of these skills is a little bit slower. It's particularly more gentle for standing. And this makes sense. These are harder skills to recover, and it would take more time for indeed those to do so. But indeed, what we found was that by the end of the year, the majority had regained that pre-operative level of skill. And the two that did not, one was still recovering from her other intervening complication, and another girl was generally weaker and was able to stand and take some steps, but not to the extent that she had been able to before her surgery. And one girl did not attempt walking after her surgery, so that explains why the regaining of post-operative skills post-operatively was not quite 100%. So when we asked the families what was stressful about the episode of spinal fusion, parents reported that the occurrence of any post-operative complications were extremely stressful to them. The surgeons had attended very carefully to the risk of complications prior to the surgery, but when those complications, if those complications happen, then that still feels extremely stressful to parents. So they lived the journey alongside their daughter very acutely. And also, if families felt isolated, then in terms of, and I will come to this more in the next slide, in terms of needing more support from their own families and networks, or from the clinicians and staff around them, then that added to their emotional burden. So very much the factors that tended to decrease their stress were feeling informed, feeling well prepared for when time came for discharge, having felt a confident, communicative relationship with the staff, and also having capacity and opportunity to be able to balance their personal needs of their daughter's care with their personal needs with their daughter's care. And that was quite important, because it really is such a complex and extensive procedure and experience. So what families wanted, they want strong clinician-family relationships. That means regular, clear, consistent information. And when decisions are made, for example, in regard to pain management or activity or other aspects of care of other issues such as reflux or constipation or epilepsy, for decisions to be made taking into account the family's knowledge and point of view. Families wanted to feel very reassured that they had the A-team with their daughter's care. They wanted confidence and experience in the family and in the staff, and they also wanted to very much valued when they perceived a very strong proactiveness in dealing with what the next step needed to be. And families spoke particularly about pain management, and typically pain management is very well managed in ICU settings, and they very much valued when those strong pain management regimens transferred accurately over to ward settings, and that its reduction was the reduction in medications for pain management was the careful assessment for that was replicated as it had been in intensive care on the ward settings, and that makes sense. And also from the point of view of over the longer term, because some of our families are several years down the track from having had a spinal fusion, they valued visiting their spinal surgeon for monitoring of the spine, and for their therapists and their clinicians to be aware of the need to continue with attention to posture and positioning during sitting and sleeping to maintain that very, very satisfactory straight spine that has been achieved, to maintain that and to look after the child from the point of view of pressure. So follow-up was very much valued by families. So families reduced the stress and burden by being prepared as soon as they had made the decision to proceed with spinal fusion. They would start to get organised. They worked to get working to get support structures, and this means informal support. And if that is less strong in your own particular settings, then to make sure that you've got good formal support so that there can be time to support for the extra tasks of day-to-day care, but also for allowing for personal time. One mother said the biggest thing was having more time for myself, having a break, because she was very, very much more involved in providing care over many more hours of the day. This is in the early post-operative weeks. So coming back to our overall group again, there's our whole study population, and here we have at the end the 140 girls who have developed a severe scoliosis. And for this group, we include in this group all of the girls and the women who have had a spinal fusion, or if one or more of their cob angles was 45 degrees or greater at any time in their surveillance. So we've got that sort of time point of around 50 degrees where we're starting to think that this is a severe scoliosis. So the outcome that we have recently looked at is the occurrence of severe lower respiratory tract infection after a severe scoliosis. And so what we have from our very long-term follow-up with our families is that we have 12-month snapshots of every 2 to 3 years, and it's during these snapshots that we have collected information on hospitalizations that the child had required over the previous 12-month period, and the number of days that they were in hospital also, and the reason that they were admitted to hospital. So what we have done for this analysis is that we have picked out all of the overnight hospitalizations that were for a respiratory diagnosis, and we have looked at those in relation to all of those 140 girls who have a severe scoliosis. So this 140 comprises two groups of girls. Some of those have not had a spinal fusion and are being managed conservatively. That number's 42. And then there are the 98 who have had a spinal surgery, spinal fusion. And the age of onset for both of these groups of girls and women is around 8 years. And for those who had surgery, their average age at surgery was 13, and the average cob angle at the time of surgery was 73. So these data are very similar to the US data that I showed you earlier. So looking at those snapshots, what we can see is that for each 12-month period, the average prevalence of a severe lower respiratory tract infection, that is a lower respiratory tract diagnosis that required at least one overnight stay in hospital, on average in each year was 13% of all of those who were managed conservatively. So that is girls who were managed conservatively and never had a spinal fusion, and the group who, the time points for those who were managed conservatively before they went to have a fusion when they were older. And the average prevalence of a lower respiratory tract infection requiring a hospitalization in those who had had a spinal fusion was just under 10%, around close to 9%. So when we then divided this information into those who had had a scoliosis develop very early versus those who were later in the age of 8 years, we can see that the prevalence of a respiratory infection that needed a hospital admission was 3 times that in those who were managed conservatively compared to those who had a fusion. It's very similar for those who have a later onset scoliosis, but for the early onset scoliosis, suggesting that the lungs are at particular risk with a severe scoliosis, and potentially fusion is mitigating the risk of later lung pathology and events that need hospitalizations. So this is my last picture of graphs. So this is just showing you some other examples of how we have done a physical activity study where we have collected information on steps taken over the course of a day. And here is a young girl who can walk on her own. She still walks on her own. She's over 23 years now. And this is showing 10 years after her spinal fusion, how on some days she will take a smaller number of steps, but on days when she's going out and there's an outing, She can be extremely busy, and her motor capacity is much higher on those days. So she has that capacity still 10 years beyond a spinal fusion. This graph is showing, these two little diagrams are showing you a girl who's a year post having a fusion. She walks with one hand held, and you can see that her activity is in less frequent bouts, but she is still able to walk around 2,000 steps in a day, a year beyond her spinal fusion. And this final example I will show you is a young girl. Well, she's not so young now, but when she was a little girl, she could walk with assistance. And with her scoliosis, she was unable to walk, even with assistance. And after her scoliosis, she regained, she had a fusion at quite an older age. She was 17 years. She regained capacity to walk with assistance. So this is supported walking around her chest, but she is taking steps. And you can see small number of steps in her day, but these steps are important steps for her. They are representing her walking from one room in her in the group home setting where she lives to another room. This is a walking capacity that she can use to get from one place to another within an indoor setting. And that is a skill that she has and can be proud of. Yeah. So I'm almost at the end. I would like to conclude. We have, with our work, which now has proceeded for over 22 years, we have taken a very comprehensive outcomes approach to build up right from the grassroots level a body of work and findings from which we can better understand scoliosis in Rett syndrome. And whilst I have presented a lot of findings, they are group findings, but the importance of group findings is that they are a framework from which an individual family can draw upon to make their individual decision as to what management procedures are going to work best for the family and, importantly, for the child. So this is not a presentation that is recommending any one treatment for for all girls. This is about providing a framework and illustrating where we have very poor evidence and where we need much more work and a much more sort of decision, and the clinicians need to draw on their individual experience. And we're now moving in the area of spinal fusion so that we now have a much more stronger quantitative basis for making decisions. So again, this is a group findings, and it's for the individual family to make decisions with your individual clinicians as exactly what would suit you and your daughter. The bottom line for all of the girls, whether they are able to walk or are unable to walk, is lifestyle, variety of activity, including fun, but that incorporates stretch, posture, and as much fitness, considering strength and endurance as is possible. So optimal lifestyle, not only is that likely to be valuable for spinal health, but it's valuable for quality of life and having a fun time as the children are growing older. Because Rett syndrome has many complexities to its aspects, it has other comorbidities such as osteoporosis, epilepsy. It is a complex condition to manage, and at the same time as living a very active lifestyle, it is important that optimal medical care with regard to bone health and growth, and very quick and timely management for any new onset of respiratory infections is very important. So that is optimizing health and well-being, but bone health and growth are also important from the point of view of spinal health and growth as well. So what we have found with our very detailed studies with regard to spinal fusion is that with appropriate cautions to the fragility of Rett syndrome, that spinal fusion reduces the severity of a scoliosis, that we have recovery of wellness in most cases within 12 months, and we are seeing some evidence that a straight spine will have protective effects on respiratory health. And I would like to acknowledge all of the participating families for contributing information. Our consumer reference groups for our study, we work with this group regularly, and we have often talked with them about scoliosis, and that guides the direction of our research. Our whole study team is involved in the putting together of this data, led by Dr. Helen Leonard. And we also have students that join our team from time to time, and they make a very valuable contribution. We have had NH and MRC grant funding for most of the findings reported in this study, and particular acknowledgements to Caitlin Ma, who conducted very fine and sensitive interviews for the interview study that I presented earlier. Thank you all very much for listening.
Thank you, Jenny. That is an incredible presentation, and I learned so much from what you presented, and I know all of our families have as well. We have quite a few questions in the queue.
Okay.
We're at the top of the hour, so
sorry.
No. I think many of the questions that were asked, you answered in your slide, so we're okay.
Good.
And if you're okay, and if everyone on the line is okay, perhaps we could go for another 10 minutes or so we could answer some questions. And then, like I suggested at the beginning, we can export the question log to you, and you can
write something. Yes. Okay, I'm happy with that. I do apologize for going on so long.
Oh, you didn't. Yeah, it was all relevant and important information. And I want to just make a comment. Families to please, when you're asked to complete a survey or contribute to a database, you can see how all of our individual experiences roll up into very important trend data that
absolutely
benefit all of us. So I want, just to support your work.
Yes, we count every piece of information as gold.
Yeah. So thank you to everyone that has participated in this study or into Rett or anything that Jenny and her group in Australia have been doing. So I also wanted to mention, in case people start to drop off, that you are talking tomorrow about gross motor skills in daily life and Rett syndrome. And a lot of our questions have to do with therapeutic interventions, equipment, frequency. And will you be addressing a lot of those aspects in your
in part, yes. Okay. In part I can. So I can always, what you could do is if you've got a lot of questions, what you could do is send those questions to me, and I can try to address some of them in tomorrow's, if you want. Okay. If there was a lot of questions on.
Yeah, so everybody, Jenny Downs will be presenting tomorrow on using gross motor skills in daily life and Rett syndrome, which we know has impacted many areas, including the spine and scoliosis. So, we hope that you attend that session. So let's get to some of these questions. Okay, so we have a parent who's asking if gait trainers or gait training on a treadmill help with scoliosis, in your opinion, and does hippotherapy help or worsen scoliosis?
My answer would be that I would estimate that they are both extremely useful activities. Working on a treadmill is about fitness and is about the rhythm of walking. We have done work with qualitative on quality of life, and so many families report that the rhythm of walking is very pleasurable for their daughter. But whilst they're doing something that they're liking, the treadmill walking will increase endurance, increase strength, and will have all that natural movement that helps to build strength and mitigate, as far as we can with gait, the progression of scoliosis. So, and the same with hippotherapy. There is a lot of natural movement of the spine. It's unsupported sitting without a back, and it's absolutely very important for general development of gross motor skills for the fun and joy of life and living. And also, we cannot put our hand on our heart and say that that will prevent a scoliosis, but we can suggest that the activity levels, and they are fabulous examples of activity that are good for the girls, will also protect their spinal health. So my answer is the evidence is not great, but we would estimate that that would likely be the case.
Okay. We had a question about some of your statistics that I think were possibly misinterpreted. So this is a very heavy question, but I think you clarified quickly. In one of your graphs, you reported that 73 children had died. Was that just that they had died over the course of your study, natural cause, all ages, or as the result of scoliosis surgery?
No. This our database is population based. We have recruited since 1973. This is born since 1973. So of those who have died, we have tracked. We know. This is not from Scoliosis Fusion. That number refers to the number in our database who have died over the course of our study. But the reason they are there is that they have also contributed data to our database. So therefore we have properly a representation of those who are more severe and less severe, and the ages at death have been at various ages, not specific. They are not a group who have died as a result of their spinal fusion. That's the nature of our database, is that we have recruited almost the whole of the population, and the nature of our database is that we have tracked as far as possible, and we understand who is alive now and who has died since recruitment.
Okay. Thank you. Thank you for that explanation.
Those girls are absolutely a part of our work. They're very important.
Okay. We have a lot of questions about sleep, and I'm not surprised by this, actually. We talk a lot about what to do with our girls during daytime, but a lot of parents, I've had a number of them in the queue, ask where they can purchase some of these sleep positioning tools that you showed.
Yes. Well, my first comment would be to work with that with your team who are looking after your child. So work with them as assessing whether that is appropriate for your daughter or not. The one I demonstrated is one of many systems, but it is the one that the person in our state where I'm from who is most experienced with posture care, including during sleep, it is the system that of choice for him, because it allows you to grow, and you can't grow out of this system, which if you had more like, if you can imagine sort of like a sort of half of a splint that you lie in, you're going to grow out of that. Whereas this is brackets that go at the pelvis and at the chest. And so as you grow, their position changes. That's all there is to it. So what I did have on that slide was the web address. So I don't like to promote any particular brand, but the beauty of this system is that it allows growth, and it's actually cheaper than most of the other sleep support systems. So I think maybe, Paige, if we took that web address from that slide and sent that to the parent, what would you suggest?
Yeah,
I've got the web address on the slide.
Okay. Okay, that's great. And following on to sleep, do you recommend that the girls sleep on their back with their legs open? Or what if they sleep better and are more comfortable on their side? If they have scoliosis, should they sleep on the side going into the curve or going away from the curve?
That's a difficult question. I think my preference would be supine, because on your back, because you can get you can achieve symmetry. Side lying is very easy to curl into your scoliosis. I think I prefer supine with the head raised a little bit so that swallowing is more comfortable. But again, this is supports in side lying can be useful. I think this is a decision that needs to be made looking at the girl's posture in each of these positions in her bed, and possibly I would be more interested in lying so that you, whatever the side lying position is, it should not curl into the scoliosis, because that is stiffening that curve even more by being so persistent over that 12-hour, often a 12-hour stretch of time.
Okay.
Again, this is really an area that we need to work much more systematically with, and so for clinicians to be documenting their experiences, I think, is extremely important. But clinicians in our guidelines all maintained that this was an important part of management. So we now need to work with that to move sleep support to the next level of understanding.
Mm-hmm. Okay, yeah, thank you. Okay, there's also some questions and concerns about using standards, positioning bodysuits, the Spio suits, Theratogs, positioning chairs, especially back braces. How soon should you start using them? And are there any thoughts on them actually contributing to muscle regression because these devices are doing all of the work?
Yes, yes. I think I actually don't know the answer to that, Paige. I don't know. I don't. We have very few centres in Australia who use bracing but I know there are centres worldwide that do use bracing. So this hasn't really crossed my path as much as it may have crossed other people's paths. With bracing, if the girl finds it very difficult to sit, it has a very important role. So even sitting within a brace can provide some muscle activity. So I wouldn't expect that to be detrimental for the child who is having difficulty with sitting. Theratogs are newer on the scene for supporting a girl's spine. At this point in time, I'm not aware of a study that has documented outcomes, but they make sense because they provide some support. The downside is that they are quite expensive and you grow out of them, so then you need to remeasure and be refitted for another top. The mothers, they are being used. Certainly in our experience in Australia, there are a few girls who are using Theratogs. The mothers who have used them observe that their daughter stands better when she is wearing her Theratogs. And in fact, one of the slides had a girl in a standing frame in a kitchen, and she was wearing her Theratog suit, and her mother maintained she was more stable in her standing. I can't imagine that that would reduce her muscle strength because she was getting more opportunity to stand. Again, we need guidance on this from good quality research, but it may be appropriate is all I can say there. And the other point is when I would be thinking that if I was wanting to use Theratogs, I would be interested around that 25 to 30 degree mark. This is my estimate from just what makes sense to me. You wouldn't do anything particular if it was an extremely mild curve. You would be working with activity and posture and a structured day that has physical tasks for the girl embedded in this, and that means can be guided by the family, but also by therapists and also in schools. So that's the sort of the daily life that includes physical activity. my bet is that theratogs might be something that I would be thinking about when I knew that the curve was going beyond a very mild scoliosis. So beyond 25 degrees would make sense to me. But I would have to be, I think that's an important topic for not just me to respond to, but for other clinicians and other therapists to actually respond to.
Great, thank you. I think Mayor Lotan is
the
actually...
best guess. He may be, actually, yes. So
yeah.
we need to ask him, I think.
Yeah, we'll check with him. Okay, I know we're getting very short on time here, so let me ask you, there were two questions specifically about scoliosis and surgery that I think are important that we can ask out loud, and then we can answer the rest as a QA doc.
Yes.
One is, do you have an opinion on when going for a scoliosis x-ray exam, what is the best way to get the correct curve of a fixed versus flexible curve? Should it be done in a sitting position or lying down position?
All right. I think this is also a question for spinal surgeons. Almost every single one of the curves in Australia have been done in sitting. Almost every single one. So all of our curves that we are reporting are all in sitting. And in fact, if they were in supine, we excluded those curves from our analyses because they were in a different position. So that these are sitting curves because that is a functional way to observe the scoliosis. So that's been it's almost not my question. It's been practice. And so almost all of our girls have been X-rayed in sitting.
Okay, and I can understand that because that's how you're looking at the lung cavity. The position
that's right.
That's right. Is in sitting. Okay. The second one, and this is a good question I think to close on, is do you have a sense of the reoccurrence of scoliosis progression post-surgery? So do girls or women have to have scoliosis surgery a second time?
Okay. In our 98, we have had one who has gone for an extension at a later point in time, had a second surgery for an extension of her fusion to go lower down in her spine to include the pelvis. So that was one. I can think of another one who, when she was an adult, the parents reported that her scoliosis recurred, and indeed that was the case when we went to her records. And I know of another girl who is possibly going to need her hardware extended as well. So this can happen. It's a balancing act with when the fusion should be conducted and the levels, as I said, and growth is something that you want to wait for as long as possible for the particular girl so that she can have grown as much as possible. So optimal growth is what is important prior to the surgery. So from what I'm saying, we haven't assessed this systematically, but I can think of three. So I'm thinking that the proportion who are needing to go back for additional surgery, who have a later recurrence of their scoliosis, my guess is that is likely to be a small proportion of the girls.
Okay, fantastic. Okay, so I'm going to type in here into our question box and send to all the website address for the sleep aid.
Yep. So that put that into your decision making. Yes.
Yeah. So we have a number of questions. We'll get those to you, and I know you'll help us develop a question and answer document, which I think will be really helpful for everybody. Thank you so much for your presentation, Jenny. It's fantastic, and we look forward to hearing from you tomorrow.
Yes.
Yeah.
I look forward also.
And I know we can count you on as part of the long-term team with Rett syndrome-related disorders. So this won't be the last time we'll have a chance to speak with you.
No, it's a wonderful opportunity, and I thank you, Paige, and your team.
Yeah, thank you. Good job. And thank you to all of our attendees for hanging in with us, and thank you for supporting RettSyndrome.org. We just think it's incredibly important to continue educating you about what's going on with your children while we are pursuing research towards treatments and a cure. So thank you for being with us today. We look forward to having you join us for more webinars tomorrow. Have a good evening. Jenny, have a great day.
Yes.
And this will conclude our webinar tonight. Thank you so much. Bye-bye.
Thank you. Bye.